Hi, my name is Jenna Talley, and I'm doing my presentation on muscular dystrophy. So to start, I thought it would be extremely helpful to understand exactly what muscular dystrophy is. So muscular dystrophy, or MD for short, is a group of more than 30 genetic diseases that are characterized by progressive weakness and degeneration of skeletal muscle that controls the movement of the body. Affected muscles become progressively weaker, and most people that have this condition unfortunately have a shortened lifespan due to medical complications associated with the degenerating muscles. So MD, muscular dystrophy, is kind of an umbrella term to cover a bunch of different disorders that all do the same thing. They all break down muscle. So the major issue is that the protein dystrophin is prevented from being made properly in the body due to this genetic screw-up. This is necessary to maintain a healthy muscle. The cause is genetic and directly linked to the X chromosome. Because of this, boys are more likely than girls to have MD. Boys only have one X chromosome, so if their mother is a carrier, then they have a 50% chance of having MD. Girls can carry MD as a recessive trait, but typically they are not seen to have MD. It's very rare. So what is dystrophin? And why exactly is it so important? Well, someone with muscular dystrophy actually has the absence or deformed dystrophin gene. Dystrophin is an essential protein made in the body that connects the cytoskeleton of a muscle fiber to the surrounding extracellular matrix through the cell membrane. When it functions properly, it prevents the membrane of the myocyte from becoming torn or damaged during muscle contraction. So if there is an absence or if there is a deformed dystrophin, this protein will not be working properly and will allow a tear in the membrane of the muscle fiber. This will cause an influx of calcium ions. The flood of calcium ions typically causes the activation of proteinase. These proteinase are sent in to dissolve damaged proteins when contraction occurs, but when too much flood in, they will actually attack healthy proteins instead. Eventually, this will completely break down the muscle into fat, and fat does not contract as muscle does. When calcium comes into the cell, creatine kinase will flood out of the myocyte and reduce the energy stores inside of the muscle. This is actually one of the ways that the doctors can test to see if someone has muscular dystrophy, because the levels of creatine kinase in the blood will be elevated. So what are the major types of muscular dystrophy? So they are grouped together and classified as dystrophinopathies. The two that fall under this category in particular are Duchenne's and Becker's. Duchenne's is the most common, occurring in 1 per every 3,500 live male birth cases, while Becker's comes in second, occurring 1 in every 30,000 live male births. A couple of others that are worth mentioning are limb girdle dystrophy, which occurs in 1.3 of all patients with MD, fasculoscapular humeral type, and oculopharyngeal type. Alright, so the difference between DMD, Duchenne's muscular dystrophy, and BMD, Becker's muscular dystrophy, are the onset of signs and symptoms. Duchenne's MD starts to appear around the age of 2 or 3. This is due to a complete loss of dystrophin. It progresses very quickly, and the life expectancy for this is between 20 to 30 years old at most. Becker's has the same signs and symptoms as DMD, which will be explained in the next slide, but they do not start to show these signs and symptoms until later in life, around 10 to 20 years old. This is due to a misshapen dystrophin as opposed to an absence of dystrophin. So the dystrophin is present, but it may not be long enough to reach both ends from the matrix to the membrane of the cell. So the signs and symptoms, as I started to mention, they're the same for both Duchenne's and for Becker's. you will see very distinct signs and symptoms. You will see, for instance, frequent falls, difficulty getting up from a lying or sitting position, trouble running and jumping, a waddling gait, walking on the toes, large calf muscles, muscle pain and stiffness, and possibly learning disabilities. So when I talk about difficulty getting up from a lying or sitting position, I don't just mean that they struggle to stand or that it takes them a little bit. There's a very distinct standing pattern. To get up from a lying position to a standing position, you will see what is known as grower's sign. This is depicted in the picture at the top of the slide. The child will actually start on their stomach, push themselves up with their hands, place one hand on a knee to push up their body, and then slowly they will do the same with the other arm and knee. They will bring the knee up to a standing position, push themselves up with their other hand. They will eventually have to walk their hands up their legs, and then they will throw their shoulders back. This is the only way that they can stand, and this is actually very common to see in anyone with muscular dystrophy. So treatment methods, there's absolutely no cure, unfortunately. This is genetically inherited, and there's not much researchers can find on how to treat it. Medication options include corticosteroids. The most common is known as prednisone, which can only improve muscle strength and delay the progress of certain muscular dystrophies, but in the end, it does not actually cure the muscular dystrophy. So 0.75 milligrams per kilogram of prednisone is found in numerous studies to be the most effective drug. They basically only found that it stabilizes the muscle strength for a period of time. There are some severe adverse side effects, such as weight change, mood change, and GI distress. There's also issues with blood pressure that have been seen. Also, some heart medicines have been prescribed because sometimes muscular dystrophy will actually damage the heart as well. So what about exercising with MD? Is that even possible? So some studies say that cardio exercise testing seems to be pretty promising in youth with mild limitations to functioning. This includes treadmill and bike ergometer tests. There's no obvious benefit to this type of testing yet, but there's also no harm either. So when I say mild limitation to functioning, I typically mean that they are not wheelchair bound yet. They're still able to walk. Some say that moderate intensity strength training and aerobic exercise training also do not appear to do any harm to the subject, but they don't provide any sufficient evidence of benefits either. And lastly, low-intensity physical activity is thought to be safe and effective in reducing disuse atrophy and excessive functional loss. Those two terms can kind of go hand in hand, but again, it's just a thought, it's not proven. So for my case study, I have a patient who is 5 years old and he's a male. The risk stratification, he has difficulty getting up from a lying position. He can walk, but he is much slower than his peers. He has a waddling gait and large calf muscles. So he is in the risk group of progression of muscular dystrophy, and specifically it would be Duchenne's. The goal would be just to maintain muscle tone for as long as possible. He is still walking, so the goal is to keep him walking as opposed to put him in a wheelchair. And we want to slow the regression of muscle tone and reduce disuse atrophy. So some special considerations. Exercise is definitely possible for people with muscular dystrophy, but intensive exercises such as HIIT or powerlifting are unnecessary and in fact should be avoided. This is because those tend to be for increasing muscle capacity, and with people with muscular dystrophies, we already know that any type of exercise, for the most part, does not show any increase in muscle working. So we need to not have them put as much stress on their bodies because it could just be painful and not have any real benefits. So exercise testing. Studies have shown that the 6-minute walk test is the best for those with Duchenne's muscular dystrophy. It shows no adverse effect in patients that have participated in it, and it gives mostly accurate depiction on how aerobically fit the patient actually is. So we're going to do that for our child. Flexibility, We want to make sure that we reduce the rigidity because it's really important that the muscles, if they do become atrophied, they tend to stiffen. So we want to make sure that our exercise prescription, we're not overworking the muscles as to reduce the flexibility, because this could adversely affect the balance, which is also a concern of ours. The muscle strength test we will perform is called a motor faction test or a motor faction measure. This measures the change in motor functions, and so this would take the place of a 1RM. We are interested in maintaining what our client has instead of gaining motor function and more muscle. So instead of performing a 1RM, we're just going to have him do motor faction measures for hip extension, knee extension, ankle dorsiflexion, shoulder abduction, and wrist and elbow extension. So we also want to know the height and weight of our client and the BMI just to keep a running record of where he stands in comparison to his developing peers. He's only 5 years old, so he is still growing. The exercise prescription for my client, I decided that it would be 30 minutes a day, 5 days a week for 24 weeks. Then we would retest to see if the muscle atrophy has slowed. It would be 15 minutes of arm cycling and 15 minutes of leg cycling. The goal would be 700 to 1,000 revolutions, both leg and arms, during the training session, and the cycle would be at a continuous speed. Intensity should reflect what the patient believes they can sustain for the full exercise duration. Yes, he is only 5, but he does have muscular dystrophy, so we don't want to have him in pain or overworked. Heart rate is not an essential factor in this prescription because the goal is not to exhaust the client or make him feel like he's in any sort of pain. The goal is just to keep him engaged at a fairly low, constant speed. So a website that I actually went on recommended that you have the child watching TV to keep them motivated and make it a little bit more fun. So, in conclusion, there is a major lack of information on the effects and/or benefits of exercise on muscular dystrophy. With more research and studies, perhaps those with muscular dystrophies could see improvement instead of just maintenance or nothing at all. So, although those who struggle with muscular dystrophies may not see improved muscle fitness with exercise, they have the possibility to maintain the muscle tone that they still have and reduce the muscle wasting away and the speed at which it occurs. So overall, exercise is essential for absolutely everyone, especially those with muscular dystrophies. I want to point out that I actually have a few videos in this presentation, one of which is on Duchenne's muscular dystrophy and Becker's muscular dystrophy, signs, symptoms, and treatments. That one was extremely good and taught me a lot about the disorders. Also, there's 2 under Duchenne's muscular dystrophy that just kind of talk about the Duchenne's timeline and how long a child may have. So those are really good if you get a chance, and they're very enlightening. Here are my references, and that is all. Thank you for watching, and let me know if you have any questions.